Hi, I'm Warren Friedman. I'm an assistant professor of medicine at Weill Cornell Medical College. I'm here today to talk to you about a new technology for treatment of pulmonary embolism. So here you can see below is the outline of our talk. I'm going to start by talking about pulmonary embolism definitions, and you can read below what we're going to move on to. So acute pulmonary embolisms are commonly divided into three major categories. Over on the left-hand category, we have what's called a massive pulmonary embolism. And this is defined by unstable hemodynamics. The technical definition is a sustained systolic blood pressure less than 90 for more than 15 minutes. In the middle, you have submassive pulmonary emboli that are patients that are normotensive and normal hemodynamics, but they have echocardiographic evidence of right ventricular dysfunction, or they have other evidence to lead you to believe that they have right ventricular dysfunction, such as elevated troponin, BNP, or EKG changes. On the third row, you see low-risk pulmonary emboli. These are the patients that have not only normal hemodynamics, but have no evidence of right ventricular dysfunction, and they have the lowest mortality, as we'll see in the following slide. The reason we risk stratify pulmonary emboli according to hemodynamics is that hemodynamics have a major impact on the mortality of pulmonary emboli. For low-risk pulmonary emboli, we're looking at very low mortality risks. These are patients that for the most part you can leave them alone, they can get anticoagulated, and you don't need to escalate therapy. However, as soon as you start to develop signs that your RV is hurting, then the risk of mortality raises up to 3 to 9%, but also the risk of an adverse event raises as well. And that can include need for mechanical ventilation, worsening hemodynamics, or even circulatory collapse. And that becomes a very important thing when you're risk stratifying a submassive pulmonary embolism, because you need to be prepared that some of the course in these patients will become quite rocky. Lastly, in the red zone here, we have massive pulmonary emboli, and they carry with it, as you would expect, a very high mortality rate. These are the kind of patients where you need to do something for them. It is not okay to simply just anticoagulate these patients and walk away. In the MAPIT registry, we could see that when you have a normotensive patient, you can see that the mortality rate can be actually quite low. When you have a normotensive patient with right ventricular dysfunction, the mortality rate may be around 8%. That goes along with the slide just preceding. As soon as you develop systemic hypotension, your mortality rate gets even a little bit higher. When you develop cardiogenic shock, you can see it raises even further. And then, of course, the highest mortality rate is associated with CPR. I'm now going to move on to massive pulmonary embolism. So this is a patient with massive pulmonary embolus. He's a 44-year-old male who has sudden shortness of breath, tachycardia, hypoxia, hypertension, but then an hour after this CAT scan, he suddenly develops loss of consciousness. He drops his blood pressure to the point that he barely has a palpable radial pulse. He is cold, and your systolic blood pressure may be only in the range of about 60. This is the definition of massive pulmonary embolism. And this is what we're trying to avoid. This is an autopsy finding of bilateral lobar and main and segmental pulmonary emboli completely obstructing the circulation. So what are your choices when you're faced with a patient like this? Well, of course, there's heparin, and all patients with pulmonary embolism should be anticoagulated at the least. There's IV systemic thrombolytics that has historically been the major modality of escalating therapy in patients who are unstable. We now have some new techniques, including catheter-directed therapy, to approach pulmonary emboli, and we'll be speaking about that later. And there's been a resurgence in surgical embolectomy. Guidelines strongly support the use of IV systemic thrombolytics in massive pulmonary embolism, and the newer guidelines also suggest that if you anticipate your patient's about to become rapidly very unstable, you should also consider escalating to IV systemic thrombolytics in those situations as well. With that, we're going to talk about some of the data and the evidence behind using systemic thrombolytics in the massive pulmonary embolism population. This is a meta-analysis that came out in 2004 looking at all the clinical trials of systemic thrombolytics and massive pulmonary embolism to that date. And when they pooled those trials that included hemodynamically unstable patients, there was a significant difference in death or PE recurrence between the group that got heparin alone versus lytics. And you can see that that difference was quite profound. This is a trial in 2012 in which they used a database of the nationwide inpatient sample from 1999 to 2008. They were able to look at 72,000 patients with pulmonary embolism, and they were able to look at those patients who became hemodynamically unstable. And you can now see that with thrombolytic therapy, the mortality rate was dramatically lower than with those patients who did not receive thrombolytic therapy. Now, granted, this was not a randomized controlled trial, and there were differences in samples between the thrombolytic group and the no thrombolytic group. In fact, for the patients who did not receive thrombolytics, they did have some increase in major comorbidities. However, even when they separated out to look at patients with similar comorbidities, the mortality difference stood. Unfortunately, you can see in this slide that the use of IV thrombolytics has actually decreased with time, even as we've gained and accumulated data to suggest that there's a major mortality benefit in this patient population. The reason is probably that doctors and physicians are extremely afraid and concerned of the bleeding complications of IV thrombolytics, and oftentimes doctors would rather commit a sin of omission than commission. They would rather not be responsible for a bad outcome that could possibly happen rather than simply not doing a therapy and then having that patient go on to have a bad outcome. Well, what happens when you decide that you need to give IV systemic thrombolytics to a patient, but perhaps they have a CAT scan like this one above and they have a major brain tumor, in other words, a very strong contraindication to giving IV systemic thrombolytics? Well, with that, we're going to move on to the indication of surgical embolectomy. And surgical embolectomy for long term has been the tool that we use when we believe we need to escalate therapy. This is the kind of patient that you want to push IV systemic thrombolytics in, but you simply can't because they meet a major contraindication. Surgical embolectomy has also historically been used for the situation in which you have a clot in transit. So on your echocardiogram, you see a clot in the right atrium or the clot in the right ventricle, and these people have a very, very, very rocky course, and the indication for surgical embolectomy is certainly there. Now, for long-term, surgical embolectomy has been considered a total death knell. People have actually graduated cardiac surgery fellowships without ever once performing one of these surgeries because the mortality rate was seen to be in the 20 to 30% range. However, a series out of Brigham in 2005 showed that the survival is actually as high as 96% at 30 days and 86% a year. And whether this has to do with patient selection, which is what I think, but also possibly an improvement in technology, improvement in cardiopulmonary bypass, and an improvement in surgical technique, it is probably a little bit of all those things why the mortality rate is a little bit higher. You should be familiar with your own institution's capabilities and whether or not you have a cardiac surgeon who's willing and interested in doing this particular type of surgery. This is actually a picture of a patient that we had about 10 years ago who we took to the operating room for a clot in transit, and he did quite well on the operating room table. But there's some other very important things that should be stated about surgical embolectomy. Namely that even though we use this in the situation where we think the patient is too high of a bleeding risk for IV systemic thrombolytics, bleeding risk is not scot-free with cardiopulmonary bypass. In fact, you need tremendous amount of heparin to go on cardiopulmonary bypass, so bleeding risk is still there. Of course, you need to induce anesthesia, and for these very unstable patients, that could actually precipitate hemodynamic collapse. You need to have proximal clot in order for the surgeon to be able to get at that clot and remove it. And lastly, again, you need to remember that there are significant improvements in mortality in this procedure, and like anything else, it has to do with patient selection. A bit of a word about veno-arterial ECMO. Veno-arterial ECMO can be used as a standalone treatment for very unstable pulmonary emboli patients. In other words, your patient's in shock, you cannulate them, you put them on veno-arterial ECMO, which means a cannulation in the femoral vein and femoral artery, and the blood is now circulated outside the body in a modified or simplified cardiopulmonary bypass circuit. The pump is used to create flow, and the oxygenator is used to create oxygen and also to remove carbon dioxide. This can actually be a very good technology for pulmonary emboli as it completely bypasses the right heart. You could place that patient on heparin and actually put them on cardiopulmonary bypass and wait for the situation to stabilize and the circulation to stabilize. Or you can use veno-arterial ECMO as a bridge to a more definitive therapy. That definitive therapy possibly being surgical embolectomy or even catheter-directed thrombectomy. Now we're going to move on to submassive pulmonary embolism. And I'm going to give you a case of a submassive PE. This is a patient who was 44 years old. He had a long plane travel about 2 weeks prior. He was a very active patient. He could run around 3 miles a day. And then very rapidly, over a period of about 2 days, he recognized that he had difficulty even climbing up the subway steps here in New York City. He couldn't even take 3 steps. You can see on the next slide some of his vital signs. Particularly concerning is the elevated heart rate at 120. You can see that he's quite hypoxic. He's 88% on room air, but he's actually hypertensive. Okay, so he technically fits in the submassive pulmonary emboli population because his bedside echo, which I'll show you in a couple of slides, did show RV dysfunction. His PE protocolized CT showed bilateral lobar pulmonary emboli, and you can see that he had an elevated BNP and a troponin. The significance of this I will get to later in the lecture. This is his CAT scan. You folks will recognize that at the distal left pulmonary artery, there's a very large clot burden. You can also see on the right side that there's a very large clot burden extending from the main pulmonary artery into the lobar pulmonary arteries and then down into the segmental branches. This is a clip from his echocardiogram showing a very elevated tricuspid regurgitant jet, so his pulmonary artery pressures were certainly quite elevated. You should be thinking to yourself, what are my options in this type of patient? So this is not a patient who's hemodynamically unstable, but this is a submassive pulmonary embolism patient. Well, certainly the options for heparin, IV systemic thrombolytics, catheter-directed therapy, and surgical embolectomy are all there, but increasingly I see a role for this particular patient population using catheter-directed therapy, and we'll get to why. But first, we're going to talk about the physiology of right ventricular dysfunction, because it's important to understand the physiology before you recognize why it's important to therefore escalate therapy in these particular patients. So why do I argue that in some patients with submassive pulmonary emboli that we should escalate beyond anticoagulation and move towards systemic thrombolytics? Because even though you may call their hemodynamics quote-unquote stable, I see nothing stable about right ventricular dysfunction. I think that this is quite a hemodynamically unstable situation. And in this picture, you can see that the right ventricle is quite large, it is hypocontractile, and if you did a parasternal short axis view, you would see that the interventricular septum was pushing into the left ventricle. And let's talk a little bit about what this means. So, when you have a clot that breaks off in your common femoral vein, travels through your right heart, and lodges in the pulmonary artery system, it immediately leads to a pressure load, an increase in pressure on the right ventricle. Now, your right ventricle is used to operating under very, very low pressures. When that pressure rises, your RV begins to decompensate. First, it dilates, then it can also become hypocontractile. When your RV cardiac output falls, your LV cardiac output, your left ventricular cardiac output, must therefore fall because your right ventricle and your left ventricle are linked in series. Your left ventricular cardiac output can never exceed your right ventricular cardiac output. But there is an additional factor of interventricular dependence in which the right ventricle and left ventricle are also linked in parallel. And that's because they share an interventricular septum. And as your right ventricle begins to fail, your interventricular septum begins to push into the left ventricle. And when it pushes into the left ventricle, it further impedes LV diastolic filling. So there's a double situation of why your LV cardiac output begins to fall. Now, when your left ventricular cardiac output falls, eventually your systemic blood pressure falls. And the right ventricle is also quite prone to ischemia. The right ventricle can become ischemic even in the absence of coronary artery disease, and it's via the following concept. The right ventricle is used to being perfused under a low pressure situation. So the difference between your systemic blood pressure and your RV intercavitary pressure equals your coronary perfusion pressure. And when your systemic blood pressure falls, or your right ventricular pressure rises, your coronary perfusion pressure will therefore fall, and then your right ventricle will become ischemic. When your right ventricle becomes ischemic, the right ventricular cardiac output falls, and then this entire cycle starts all over again as your LV cardiac output falls. So after that slide, you may say, well, why aren't we lysing all patients with right ventricular dysfunction? And well, the obvious answer is it's because of the bleeding risk. And it's not small. With IV systemic thrombolytics, we are talking a 20 to 30% increase in major bleeding, or incidence rather in major bleeding. We're talking about a 3 to 5% risk of hemorrhagic stroke, which is a devastating complication that we all worry about. I do, however, want to remind everybody that bleeding is not uncommon with heparin alone. A lot of the patients that I believe bleed on IV systemic thrombolytics, may actually be bleeding because of their heparin as well. Heparin will also lead to significant bleeding. It's important to mention one important disadvantage to systemic thrombolytics in the submassive population. And that's if you took a patient with submassive PE and you gave them thrombolytics, and then they did have a bleeding complication. Well, now you can't give them the heparin or the low molecular weight heparin that you were going to in the beginning. Now you have to place an IVC filter in them, and then you have to wait till the bleeding stops before you can anticoagulate them. And you may have made a mess of the situation because now you may have several days of a patient with an acute fresh clot in which they have to stay off of anticoagulation medicine. So that's a serious disadvantage, and that's something that we think about a lot when we're making that potential decision. And as we'll get into later in the talk, if we deliver the thrombolytics through catheters, we may be able to potentially avoid that bleeding risk and make the entire use of thrombolytics a safer option. So the way I look at this is that there's a simple logic here. If you think that the patient in front of you is more likely to die from their pulmonary embolism than they are to have a complication of the therapy, the IV systemic thrombolytics, then you should proceed to that therapy. So with that, I'm going to talk further about risk stratification, because the real key is, how can I pick the appropriate patient that I think is going to be sick enough to be more likely to have an adverse event than I think they will have an adverse event from the therapy of IV systemic thrombolytics? Well, first of all, you need an echocardiogram. I think this is one of the most, if not the most important risk stratification tool in pulmonary embolism. When you have a normotensive patient in front of you, up to 30% of them will have echocardiographic evidence of right ventricular dysfunction. And as we discussed in that previous slide, once you have RV dysfunction, you are dangerously close into falling into that spiral towards circulatory collapse. 10% of patients with right ventricular dysfunction will in fact progress to shock. And out of the 30% that have this, 5% even have an in-hospital mortality. So very important to get an echocardiogram up front. Here's an excellent graph looking at outcomes in pulmonary embolism, in which we can see that obviously you have the patients up here that present either in cardiac arrest or with sudden death that have a very, very, very high mortality associated with them. Over on the left-hand side, you have patients that are completely normotensive and low risk with low clot burden that have a very low mortality. But right in the middle is where our submassive pulmonary embolism patients lie. You do have some patients with quite low mortality, but over on this side of the gray curve, you can see that some patients actually have a mortality rate that almost approaches those patients who are hemodynamically unstable. The key is in identifying these patients on this side of the category and figuring out how we can get them better and more aggressive care. I'm going to ask you to pause the recording at this point in time and pay attention to this diagram that comes from the European Society of Cardiology. This is what I like to call the right ventricular spiral of death. And you can see some of the factors that we discussed in a couple slides ago. Now, superimposed on this are some of the things that I look towards predicting that these patients may be risk for developing this quote-unquote spiral of death. Well, certainly, as we already discussed, it's very important to get an echocardiogram. It turns out that if you have an elevated troponin or BNP, so either of these biomarkers also predict a worse course. An elevated lactate, as we'll get to in a moment, is also highly predictive of a bad outcome. It actually turns out that from the CAT scan alone, you can actually predict a bad outcome as well. There's several nice studies that are now out there showing that looking at the right ventricular size to left ventricular size on a CAT scan alone can predict patients who are likely to have an increased 30-day mortality. And in fact, on the patient that I just showed you previously, he did have a right ventricular size to LV size that was larger. So therefore, you can now understand that that patient had RV dysfunction and elevated pulmonary artery pressures. On a CAT scan, you can also look for reflux of contrast in the hepatic veins, and that indicates that there is elevated right-sided pressures. This should not happen if your right-sided pressures are normal. It also turns out that if you have residual DVT, that is also associated with an increased 30-day mortality than if you do not have residual DVT. And if you have an elevated lactate, as in many other situations in critical care, these patients are also more likely to have death, as you can see from this study as well. There have been many studies that have also looked at combining multiple risk factors to see if they can come up with a better tool to risk prognosticate patients with pulmonary embolism. In this particular study, known as the PrEP study, they took 570 patients with consecutive pulmonary embolism and analyzed them. They looked at all these different risk factors, and then they came up with those risk factors that were most predictive of a bad outcome, which was what you can see below. It turns out, as we've long-term learned, that the amount of clot that you see on a CAT scan is less predictive of outcome than these hemodynamic variables. They came up with a risk stratification tool and a score, giving points to either of the above: altered mental status, cardiogenic shock, cancer, BNP, and echo showing RV to LV ratio that was increased. And they grouped them into 3 categories: class 1, 2, and 3. And you can see the risk in normotensive patients if you are either in class 1, 2, or 3. And you can see that if you fall into class 3, even if you're normotensive, you have a little over 20% risk of an adverse event. This is another interesting study where they looked at 90 patients with pulmonary embolism, looking at their echocardiograms and looking at troponin, and then looked at their 90-day mortality. The people who had a normal echocardiogram and a negative troponin had the lowest mortality. These are patients that often can be treated at home. They had the best survival advantage. If you had a combination of right ventricular dysfunction on your echo and an elevated troponin, that had the highest positive predictive value for an adverse event. If you had an elevated troponin alone, that also predicted an adverse event, and it predicted it slightly more than if you had echocardiographic evidence of right ventricular dysfunction. The combination of having echocardiographic evidence of RVD and having an elevated troponin was the most predictive of a bad clinical course. And here is the Pulmonary Embolism Severity Index, a very, very useful index. And on the right-hand side is what is known as the Simplified Pulmonary Embolism Severity Index. You can see that several factors are in there, such as age, gender, presence of cancer, previous cardiopulmonary status, and also some clinical features. This score was designed to be used before you have any additional laboratory or echo evidence. This is a score that you can do right as you approach the bedside initially with a patient. And you can very quickly stratify someone into a very low risk category, an intermediate risk category, and a high risk category. The European Society of Cardiology recommends that we should be using a Pulmonary Embolism Severity Index, or the simplified version, first, and then moving on to further testing and further risk stratification. You can see that the lowest risk patients have a very low risk Pulmonary Embolism Severity Index, and they have no echo evidence of RVD or any biomarkers that show RVD. In patients that have an elevated Pulmonary Severity Index and have either an abnormal echo or an elevated troponin, they go into what they call the intermediate low category. One step above that is if both echo evidence and biomarker evidence of myocardial injury exist, and you have evidence of a higher pulmonary embolism severity, then you're now so-called in the intermediate high category. And of course, the patients that are in the highest category are those patients that are clinically unstable. If you have a patient that is unstable, there's really no need to go ahead and calculate any of these scores, because you immediately know that bumps them right to the top. So with that, I'm now going to move on to some very important randomized clinical trials looking at systemic lysis in the submassive pulmonary embolism population. This trial came out in 2002. The New England Journal of Medicine, they enrolled 250 patients. These were patients who were hemodynamically stable with submassive pulmonary emboli, and they were randomized to either upfront IV thrombolytics or heparin, with the option to use rescue thrombolytics if they therefore then became hemodynamically unstable later in their course. You can see they met their clinical endpoint, which was a combination of death or hemodynamic deterioration. It's important to notice that in this trial, that mortality rate was really, really low. There were actually only 4 deaths in the thrombolytic group and only 3 patients in the heparin group. These are super low rates. These are not the kind of patient population I'm talking about thrombolysing. I'm talking about thrombolysing a patient population that has a much, much higher likelihood of mortality. But the escalation was much higher in the heparin-only group. In fact, rescue thrombolysis was performed 3 times as often in this group for the reasons including cardiogenic shock, hypotension, need for vasopressors, or respiratory failure. And when you think about that to yourself and you say, I'm going to decide to not thrombolyse this patient and put them on heparin alone, you also need to be thinking to yourself, what will I do if they deteriorate? How fast will I notice that? Are they getting put into the far corner of the hospital on a heparin drip where they might arrest in the middle of the night and not be noticed? Or are they being put in a place where you can watch them? And this is where real life diverges from clinical trials. In real life, your likelihood of rapidly getting to the patient that's hemodynamically deteriorating who you decided not to use upfront thrombolysis may be a lot lower in clinical trials. In clinical trials, patients are being watched like hawks. So I think there's an important bit that should not be misleading about clinical trials for thrombolysis. in that you have to imagine in real life that you're able to get to these patients and rescue them. So I would argue that a lot of the deteriorations, the ones that were rescued with thrombolysis in real life, may have actually been deaths if they were put on the regular wards. This is a very broad population of submassive pulmonary emboli. It did show that the outcomes were not worse, as long as the patients were carefully selected for low bleeding risks. However, the clinical endpoint was driven by the no need to escalate to thrombolysis, not mortality. In other words, it was the clinical course that drove the endpoint, the hemodynamic deterioration, and it was not mortality. They did not meet statistical significance for mortality. However, upfront thrombolysis certainly did not show a worse outcome, and you can argue by portending a better clinical course, it still may be indicated in many patients. This trial was debated for 10 years, and there are people falling on opposite camps of whether or not we should thrombolyse patients, with a lot of people saying, all this showed me is that I simply can wait, follow these patients, and be prepared to use IV systemic thrombolytics if they deteriorate, but I don't necessarily have to use that up front. Well, then this trial was published in 2014. And in fact, it had 1,000 patients. This is the PYTHO trial. It had more patients than were combined in every single randomized clinical trial up to date. So this is pretty impressive that they were able to accomplish this trial. It was quite a big feat. This trial as well took patients with submassive pulmonary embolism, but with a caveat. You also had to have evidence of an elevated troponin. So you either had echo evidence of RVD, or you had a CAT scan that looked like you had RVD, and you had elevated troponin, and you were randomized to either upfront IV tenecteplase or heparin alone. And what they found was that it did decrease the combined endpoint of death or hemodynamic instability quite significantly, but as in the previous trial, it also did not meet statistical significance in terms of the mortality benefit. And this also came at a significant cost, and that causes an increase in major bleeding. You can see here on this graph that there also seemed to be a major cutoff in terms of age, that above the age of 75, you were less likely to have a benefit from the therapy, and you're more likely to have bleeding from the therapy. Here's some of the data in graphical form. You can see that the patients who got upfront tenecteplase definitely had a better clinical outcome, as you see in blue. However, again, that came at a cost of increase in bleeding. And it turns out that there were 10 hemorrhagic strokes in the tenecteplase group. And you may say to yourself, well, out of 500 patients, 10 hemorrhagic strokes is small, or you may say to yourself that that's an unacceptably high risk, and I am not in favor of using IV systemic thrombolytics in this population. But I want to remind you that in the patients that got IV systemic thrombolytics, they were much less likely to need mechanical ventilation, they were much less likely to develop hemodynamic collapse, they were much less likely to end up getting CPR. But overall, the numbers were quite low. And my take on this is if they had taken a slightly higher risk group out of the submassive pulmonary embolism population, I think these results would have been more profound. I believe that just as the trial a decade previously was argued about and debated about over the last decade, I think this trial will also be argued about and debated about for the next following decade. So I don't know that it gave us all of our answers, but what it did show us, okay, was that it met an important clinical endpoint in terms of the hemodynamic deterioration. That's an important thing. To emphasize this one more time, there were 5 cardiac arrests in the placebo group versus 1 in tenecteplase. 8 patients in the tenecteplase group needed intubation versus 15 patients in the placebo group. In terms of major bleeding, however, 11% in the tenecteplase group and only 2.4% in the placebo group. And again, there were 10 hemorrhagic strokes in the tenecteplase group. So we definitely see that hemodynamic advantage, but we also see the problems with the bleeding. I would argue, just as I did in the previous trial, that all those patients that went on to deteriorate and were rescued in the placebo group, those patients in real life probably wouldn't have been rescued. I would also argue, as in the previous trial, that the overall rates of decompensation are still relatively low. If we're talking only 5 cardiac arrests in the placebo group, although it's a lot more than the tenecteplase group, that's still pretty low out of 500 patients. even though they attempted to use a higher risk subtype by using echo evidence or CT evidence of RVD plus troponin. So in other words, the addition of troponin was supposed to bring out a higher risk subgroup. I still think that this was a subgroup in which the amount of people who decompensated and deteriorated is a lot less than we otherwise would have expected. And that made it difficult to demonstrate the kind of results that I think are probably really out there in real life. And I just want to emphasize that if you take out the sickest of the 6 submassive pulmonary embolism patients, I think you'll find a higher risk subgroup, and I think you'll find that these patients are more likely to benefit from systemic thrombolytics. This is an important meta-analysis that came out shortly after the PYTHO trial, including several trials in the modern era. This looked at IV systemic thrombolytics in massive and submassive population, and when they took out the studies that looked only at the submassive population, they actually were able to find a statistically significant decrease in mortality and a favorable number needed to harm to number needed to treat ratio. But the signal size was small, 1.3%. So there probably is, in my opinion, a statistically significant decrease in mortality when you give IV systemic thrombolytics to this patient population. But that signal is relatively small, and you should try to pick the sickest of the sick of this population so you're more likely to do them benefit rather than harm. Another very important finding in this trial was when they looked at a cutoff of 65, it turned out that you are much more likely to bleed from IV systemic thrombolytics at an age above 65 than below 65. Your mortality benefit from getting IV systemic thrombolytics was much higher in the below 65 age group, and it actually didn't quite meet statistical significance in the over 65 age group. So age should probably factor into your decision of whether or not to use IV systemic thrombolytics in this population. With that, let's move on to the concept of some long-term benefits of IV systemic thrombolytics. We've talked now a lot about mortality, adverse clinical outcomes, but just because your patient survived a hospital discharge, you may not be scot-free. There may be some other things and some other benefits that that patient can have from escalating therapy. And these are some of them: risk of chronic thromboembolic disease, pulmonary hypertension, right heart failure, exercise intolerance. These are definite other considerations that are out there. It turns out that your clots don't disappear the way you may think they do. This came from a study in Chest in 2006, in which they looked at a rate of resolution of pulmonary emboli, and you can see that even up to 11 months, a large percentage of patients still have residual clot left. And some patients go on to develop this very devastating disease, chronic thromboembolic pulmonary hypertension. This is definitely a disease that you don't want to have. We think the incidence is around 4% in all comers. This was a study of 314 patients with acute pulmonary embolism, and they were followed up based on symptoms. Now, if you have submassive pulmonary embolism, your likelihood of going on to develop chronic thromboembolic pulmonary hypertension is even higher. The real question is, can we change this by being more aggressive with our pulmonary embolisms up front? That's a question that I don't think that there are answers to, but there's certainly some really interesting data that is starting now to come out. This was a study by Dr. Klein, in which he looked at a cohort of patients who either received heparin or heparin plus thrombolytics. These were submassive pulmonary emboli patients. He looked at their echocardiograms over time, from time 0 up to 6 months in follow-up. And in the group that got thrombolytics for the pulmonary emboli, every patient had a decrease in their RV systolic pressure, therefore a decrease in their pulmonary pressure, and all those patients had improvements in their right ventricular function. In the group that got heparin alone, it is true that the vast majority of patients did have recovery of their right ventricle over time and did have normalization of their pulmonary artery pressures. However, there was a good selection of patients that did not have recovery of their right ventricles, as you can see in red, and some patients actually had an increase in their pulmonary artery systolic pressures. The reason for this isn't totally clear, but it's possible that once you develop a clot, you may set off a cascade of all types of bad, untoward vascular complications in the pulmonary system, vasoconstriction, clot upon clot. And in some patients who don't resolve that clot on their own with anticoagulation, they may then go on to develop persistent pulmonary hypertension. This is a very provocative trial that came out within the last couple years. Dr. Sharifi randomized patients with submassive pulmonary emboli to either heparin alone or IV systemic thrombolytics. He took 121 patients, and in the thrombolytic group, instead of giving the full dose of alteplase, 100 milligrams, which is the typical dose we use, he used 50 milligrams, a half dose. And then instead of necessarily looking at death or hemodynamic deterioration, he decided to look at pulmonary hypertension long-term. In fact, he picked 28 months. And you can see that in the group that got thrombolytics, the low-dose thrombolytics, they were much less likely to develop pulmonary hypertension than the group that got a heparin alone. Very interesting findings. Not only was this the first randomized trial that I'm aware of that showed an outcome of decreasing long-term pulmonary hypertension in the submassive pulmonary embolism group with the use of thrombolytics, he also had no major bleeding complications, possibly suggesting that this lower dose of thrombolytics has a role in decreasing bleeding rates. I'm now going to discuss who are the appropriate candidates for escalation of therapy. So when I approach a patient with a submassive pulmonary embolism and I decide whether I'm going to escalate therapy, meaning either systemic thrombolysis or catheter-directed therapy, I look at a combination of several different things. First of all, on the right-hand side, I want to know how they clinically look. I think that this is one of the most important factors in terms of deciding who and not to escalate therapy in. And you can calculate a pulmonary embolism severity index, but you'll basically be doing this right at the bedside when you look at their heart rate, you look at what type of comorbidities they have. I'm also quite concerned about patients who have syncope, because that to me implies that at one point they lacked perfusion to their brain, which implies a drop in cardiac output. I look at patients who are younger, okay, and then I look at their data in their tests. If I see a very large clot burden in their pulmonary vasculature and I see a residual DVT, that's the kind of patient I worry about. I also look at their echo and I decide whether it's a little bit of right ventricular dysfunction or a lot of right ventricular dysfunction. I'm also concerned about the patients who have elevated lactate, troponin, and BNP as well. So I'm now going to move on to catheter-directed therapy from systemic thrombolytics. And I want to emphasize that we spent a lot of time on systemic thrombolytics, learning what they do for your pulmonary vascular system, learning how they impact on the hemodynamics. Endovascular therapy has a possibility of giving you all of those systemic benefits, but without the risk. And we're going to get into why I think that's the case. When we talk about catheter-directed therapy, there's several different options. We have mechanical thrombectomy, that includes clot maceration, that includes clot aspiration. There are devices out there, including the angiovac that we'll discuss in a second. There's the angiojet, which is a device that some of you may be familiar with as its use in the cath lab in the coronary circulation. Just a quick statement about that. The angiojet in the pulmonary artery system is likely to have some safety concerns, and that's because it creates a lot of clot maceration, releasing adenosine, and it can lead to dangerous bradycardia. So there's currently an FDA black box warning on the use of that device in the pulmonary system, even though many people across the country are still doing so. We also have thrombolytic infusion catheters, and we also have thrombolytic infusion catheters that are enhanced with ultrasound. This is a study of 600 patients, non-randomized, but these were 600 patients with massive pulmonary embolism looking at the success and the risk of catheter-directed therapy. And you can actually see that the success rate with catheter-directed therapy is actually quite high, 86%. Very importantly, the bleeding rate is quite low and much, much lower than IV systemic thrombolytics. Most of the success in this study was in the patients who got IV systemic thrombolytic infusion catheters in addition to the clot maceration. So in this particular trial, as I noted, they used several different means towards catheter-directed therapy. They used different types of clot maceration, different types of clot aspiration, several different mechanical means towards breaking up the clot with catheters. Our interventional radiologists here rarely use these in the setting of submassive pulmonary emboli, and I'm going to explain why. First of all, in massive pulmonary emboli, where the patient's really, really unstable and you just need blood flow to get from the right side to the left side, it may be more appropriate to try to break up clot or aspirate clot. But in a patient that's a little bit less unstable, the last thing you want to do is to break up a clot, embolize it distally, and actually increase your pulmonary vascular resistance worse. Say there's some flow that's getting past a small clot. If I then break up that clot, distribute it outwards, that flow may actually globally decrease overall. So in the submassive population, we rarely employ mechanical means to extract clot. We focus most of the energy on using catheters to deliver the drug to the source. There's physiologic rationale why infusing lytics through a catheter directly into the clot has advantages over giving them systemically. And it turns out that when you give IV systemic thrombolytics, if you have a large clot over here, as you can see labeled B, a lot of the drug is going to swirl around in these eddies and actually go towards the lung that is better perfused, or go towards the pulmonary arteries that are better perfused. And less of that drug is going to get directly into the clot and cause clot breakage. If you're able to put a catheter directly into that clot, you may possibly get away with much lower doses of the thrombolytic drug itself for a much higher local concentration and better clot lysis. Our practice here at Cornell is to get venous access, to thread catheters into the pulmonary artery, and to first start with a pulmonary angiogram, as you can see here. This, in fact, is a pulmonary angiogram from that patient that we discussed earlier. You can see rapid cutoff of the right lower lobe pulmonary artery, where there's very, very, very little flow here. Definitely decreased flow in the right middle zone as well, and the upper zone is better perfused and has less clot burden. The pulmonary angiogram is useful in terms of laying out the map of where the clot is at its worst, so you can then put a catheter directly into the clot, as you'll see in the next slide. Catheters are then thread into the pulmonary system, into the right side over here, and into the clot going down here into the left lower lobe pulmonary artery on the other side. These little radiographic markers here show you where the infusion ports are in these catheters. The drug is then delivered directly into the clot at a rate of 1 milligram an hour of alteplase for a total of usually 24 hours. You can do the math. We generally don't go above 24 to 30 milligrams of alteplase. That is a much lower total dose than even half dose TPA, which is 50 milligrams, or full dose, which is 100 milligrams. And the idea, again, is that we have greater local concentrations of the systemic thrombolytic and lower systemic concentrations, which we believe leads to less total bleeding rate. This, in fact, is a repeat pulmonary angiogram on that same patient after 24 hours, and you may now recognize that the perfusion to the right lower lobe is greatly, greatly enhanced. This is the picture of the pulmonary artery before infusion of the lytics. Now let's move on a bit to ultrasound accelerated thrombolysis. Now there's a new infusion catheter out on the market that in the catheter itself has embedded very small ultrasounds. These ultrasounds emit energy, and there's electron microscopy here showing that the ultrasound energy is breaking up the fibrin. The idea behind this is that the ultrasound energy will potentially allow the thrombolytic drug to penetrate deeper into the clot. So you may get more bang for your buck with the lower dose of thrombolytic overall. So ultrasound assist is quite a clever technology, and certainly the electron microscopy pictures are somewhat compelling, in which they show you that the fibrin is broken down by the ultrasound. This may end up being a really important tool in catheter-directed therapy, but that still remains to be seen. I think it is important to emphasize that there are no clinical trials that directly compare ultrasound-assisted catheters to regular infusion catheters. It'll be interesting to see if those trials end up being published. There are a couple trials that show the efficacy of these catheters, and I'll be getting into those details a little bit later. We do use them at our institution. There's certainly no reason to think that using the ultrasound catheters would cause any more harm. So the benefit may possibly be there. I'm sure that there's no harm. The trials in which I'll be showing you in the next coming slides are all industry sponsored, which is important to recognize. but they do show proof of concept that the catheter seems to work with the thrombolytics, and they met their clinical endpoints. And in fact, there's a trial that came out known as the Ultima trial, in which they randomized patients with submassive pulmonary emboli as defined by RV greater than LV ratio and echocardiogram towards getting one of these catheters known as an ECOS catheter, so an ultrasound-assisted catheter with thrombolytic infusion, versus getting heparin alone. And you can see that on this slide that there was a reduction in RV to LV ratio over 24 hours. That persisted out to 90 days. You can also see on this slide here that the RV dysfunction also improved. You can see that after 24 hours, a large percentage of the patients were only having mild RV dysfunction in the ECOS group, and the rest had moderate RV dysfunction. Very few had severe, whereas in the group that had heparin alone, many patients still had severe RV dysfunction after 24 hours. And those results persisted out until 90 days, showing a vast majority of patients returned to completely normal who had the ECOS catheter with thrombolytic infusion versus 90 days in the group that got heparin alone. And this, although it was a very, very small trial, at least suggests that you can effectively restore hemodynamics and improve RV systolic pressure and improve RV systolic performance with the use of this catheter, and you can do it in a quite a safe way. So why should you care about the fact that RV systolic function improved with the placement of these catheters and the infusion of thrombolytics? Well, I'll give you two reasons. First of all, we've discussed why RV dysfunction can be such an unstable situation. So in some patients, rapid improvement of the right ventricle may be the difference between them hemodynamically deteriorating and them having a totally normal clinical course and doing quite well. In other patients who may have never hemodynamically deteriorated, I would argue that there's nothing good about your right ventricle being under stress for 24 hours. Furthermore, there's nothing good about your right ventricle being under stress for 90 days. I would argue that once your right ventricle is under stress, and once your pulmonary vascular system is subjected to that clot, you run the risk of this becoming a permanent situation. Permanent pulmonary hypertension, permanent exercise intolerance. And that gets back to some of the data that I showed you earlier, in which they followed patients out 6 months with echocardiograms, showing that some patients who only got heparin alone ended up having persistent pulmonary hypertension, and some patients actually had worse pulmonary hypertension. So if I can extrapolate that from that data to suggest that we now have a relatively safe way to improve your right ventricular performance that may give you long-term benefits, then I would say that we may be getting at a really, really important crossroads in pulmonary embolism care. That again, it's not all about simply getting your patient to survive the hospital admission. Maybe it's not all about simply getting your patient through it without them collapsing and ending up on a ventilator or ending up in circulatory shock. Maybe it's more and more about the young patient who I can deliver this therapy to, improve their right ventricular performance, improve their exercise tolerance through a very safe method. There's also another recent trial that was presented at ACC in 2014 in an abstract form known as the Seattle trial. They took 150 patients with submassive pulmonary emboli. They decided to define this based on CAT scan, meaning a CT evidence of an RV to LV ratio, and this was actually a CAT scan of one of patients I took care of, showing an elevated RV to LV ratio. This would have been the type of patient that would have been randomized in this trial. They also used an ultrasound-assisted catheter, giving a total of 24 milligrams of TPA over 24 hours. They then repeated the CAT scan and looked at the RV to LV ratio, and they were able to find that the RV to LV ratio decreased by 30% at 48 hours in the group that got the ECOS catheter compared to the group that got heparin alone. And the pulmonary artery pressures also decreased by 30% by the completion of the procedure. Now, I don't recommend repeating CAT scans as a form of assessing whether or not your therapy worked. I think it's probably best to repeat an echocardiogram, but this is another proof of concept type of paper, meaning that we can place these catheters, we can improve right ventricular performance, and in this particular trial, there were 0 major bleeding rates. There were absolutely no intracranial hemorrhages. Again, giving more evidence and more credence to the idea that catheter-directed therapy may have the benefits hemodynamically that you want with systemic thrombolytics, but without those untoward risks. When I think about who I'm going to decide to employ catheter-directed or endovascular therapy in, I think about two different patient populations. There's the patient population over here on the left-hand side, I may die from this pulmonary embolism type of a patient. So these are the patients with submassive PE that are on the high-risk side. Maybe they have an elevated lactate, maybe they had syncope, maybe they have a really, really bad-looking echo. And particularly the patients that have these high-risk features that are also at high bleeding risk. And by the way, those often travel together because the same patients that tend to have pulmonary emboli are the same patients that are the patients that are high to bleed or more likely to bleed when you give them IV thrombolytics. Patients with cancer, patients with recent surgery, patients with tumors in their head. So when these patients that are high risk, both from their pulmonary embolism and high risk for bleeding, I think they are well served by catheter-directed therapy. On the other hand, I also think catheter-directed therapy has a role in this other patient population, and that's the younger patient population, potentially the really active patients, the ones with pretty big clots that are functionally impaired at the time of their presentation. Maybe it's our patient that can only climb up 3 subway steps, and they actually may have quite a low risk of bleeding overall, but I say to myself, I can potentially reduce their clot burden up front, improve their hemodynamics, and 6 months down the road, they may be less likely to have pulmonary hypertension. They may have better exercise tolerance. And although I think the data is still yet to come to say that that's conclusively known, I think the signals are certainly there. So these patients as well, I think, also benefit from catheter-directed therapy. In deciding candidacy for catheter-directed therapy, there are some important caveats to consider. First of all, to give a bit of a summary, we believe that by increasing local delivery over systemic thrombolytics that we improve the safety overall. We believe that there's enough data out there to suggest that the technique is effective in massive and therefore we can extrapolate in submassive PE population. We also now have 2 clinical trials that show that the therapy can reduce your RV systolic pressures and improve your RV systolic performance. However, technology for clot aspiration is still in its early stages. We mostly employ catheter-directed infusions of alteplase, and very rarely do we do clot maceration and clot aspiration. Hopefully, there'll be some new devices that come out there that are a bit more effective. You also need to recognize that the benefits are not immediate. In fact, this is a relatively lengthy procedure, and the benefits are over the hours while the alteplase is slowly infused into the body. They are not right away. This is not particularly a great modality for the patient that is rapidly deteriorating in front of your eyes and where you need to do something fast. You also need to recognize that for catheter-directed therapy to be effective, there needs to be large central thrombus, as this patient has. You need to have a good place to bury your catheter into for the technology to work. When picking a patient for catheter-directed therapy, you have to make sure that the patient can lay flat. You also need to make sure that the patient isn't getting intubated simply to get them through the procedure. It's one thing if your patient's about to go into respiratory arrest and you need to intubate them in general. But if you're deciding to intubate them to get them through this procedure, you need to recognize that the active intubation alone may lead to further hemodynamic deterioration. You also need to make sure that your patient can actually be moved. If your patient can't move off the stretcher safely onto a gurney and get them into the IR suite or the cath lab suite, that might not be the kind of patient that you want to be sending out there to get this particular therapy. In fact, that may be the kind of patient that you need to move to IV systemic lytics on. And with that same mentality in mind, you really don't want to send a patient who is actively deteriorating into either an IR suite or a cath lab, laying them flat under fluoroscopy for them to simply deteriorate in the middle of a procedure. That's not really a very safe situation. Okay, a couple words about the AngioVac device. This is a clot aspiration device. It works off of basically a veno-venous ECMO circuit. A 26 French sheath is placed usually into the femoral vein. The device is attached to a series of tubing that connects it to a rotor pump through a filter, and then the blood is returned back through a separate venous catheter, usually through the internal jugular vein. By creating flow through a pump, and these are similar pumps that are used in veno-venous ECMO, for instance, you can therefore suck the blood out through the catheter, and then there are these large filters that are in place to catch the clot. And this is in fact a patient that we actually use this device successfully in to extract clot from the lower extremity. Now, the device is a bit cumbersome. It obviously involves a very, very, very large sheath. Its exact role is still under decision and still being learned, and hopefully with later generations and iterations, a similar type of technology will develop, potentially through smaller catheters and potentially through catheters that are a little bit more flexible. But in the right patient population, this can be an effective means. So to take a step back, where are we with pulmonary embolism in 2014? Well, I still would suggest and offer that there is a whole lot of clinical panic, and in fact often a retreat from those patients who have massive pulmonary emboli. These are the kind of patients that a lot of doctors want to run the other way from. Put them on heparin, run away. They're nervous about giving them IV systemic thrombolytics. Maybe the resources aren't there for surgical embolectomy. I would also offer that with submassive pulmonary emboli, there is still a whole lot of clinical sluggishness and reticence in the face of some high-risk patients. Okay. And I think some of that comes from the fact that data is a bit confusing. Some of the data out there is actually quite conflicting. But I would argue that some more of the recent data is more suggestive that an aggressive approach has some serious advantages. The disease is still deadly and is still quite prevalent. And it turns out that the decisions are getting more complicated with time as our options have increased. I think it's great that we have a whole lot of options out there. I think it's particularly great that we have the option of endovascular therapy in a large majority of our patients. But the fact is that it makes it a bit more complicated when you have more things to decide between. The appropriate testing, including echocardiography, radiology, lab work, and clinical expertise, really requires multiple disciplines being involved. This is the kind of disease that crosses between pulmonary critical care, cardiology, interventional radiology, cardiac surgery. You may even offer hematology to really get it right. It is precisely for that reason that I was one of the co-developers of our Pulmonary Embolism Advanced Care team here at Cornell. I felt that a multidisciplinary approach was necessary to getting these patients the best care, fast, and appropriately. These are the members of our team. Dr. Sista over here on the left from interventional radiology, Dr. Salemi from cardiothoracic surgery. This is Dr. Jim Horowitz from cardiology. We also have adjunct members in hematology. We formed a team that is multidisciplinary, that is available 24 hours by activating a page. Our 24-hour pager is one clot, so it's easy to remember in an emergency. It gets you rapid access to expert echocardiography for risk stratification, rapid triage by expert resuscitationists. These are people who are interested in this disease, that are passionate about this disease, that take these patients seriously. We rapidly get you to the appropriate level of care, and we rapidly triage you to the appropriate intervention. How does this work in real life? Well, I'm about to show you. Say you have a patient right here, and this is their CAT scan. Very, very large clot on the right-sided circulation. Everybody says, oh no, this patient's sick, I better do something. Let's page the one clot team. We arrive on scene. We immediately begin clinically assessing the patient. We take a look at how they look, what's their heart rate, what's their oxygen saturation. And in doing so, we rapidly assess their risk of bleeding because it's going to be very, very important into our next decision. We then do an echocardiogram right there at the bedside. In this case, you can see a parasternal short-axis view of a very enormous right ventricle. This is one of our patients with submassive pulmonary emboli that we escalated care on, and a very, very underfilled small left ventricle. This is the kind of patient where we rapidly decide probably anticoagulation alone is not going to cut it. Perhaps we decide that this is best served by catheter-directed lysis. Maybe we decide that this patient looks so poor and looks so unstable that we proceed to systemic thrombolysis. And in some situations, we may decide on surgical thrombectomy or ECMO as a bridge to surgical thrombectomy or as a bridge to catheter-directed lysis. In making this decision right here, this is the crux of the matter. And I won't pretend that it is easy to decide amongst all these particular options. Basically, now after my lecture, you can see that a lot goes into that decision, a lot goes into that risk assessment. And certainly you can use that pulmonary embolism severity index. You can use that index with a combination of echo, and biomarkers. I recommend that you come up with an approach that best suits your institution. And lastly, I'm going to conclude on a general algorithm or guideline that we tend to use. We don't follow this absolutely strictly, but this gives you an idea of how to approach these patients. So after we've made that clinical assessment, after we've gotten that echocardiogram and we looked at that CAT scan, we then decide, I either have a patient here that is non-massive, they're very low risk, they can be anticoagulated alone. Maybe even it's the kind of patient that can be discharged. Or I decide that I have a very unstable patient in front of me. All right, this patient is hemodynamically unstable. I need to do something. And then I next say to myself, well, if they're a low bleeding risk, I'm probably going to proceed to full dose systemic alteplase infusion. If I think that they're a higher bleeding risk, these are the kind of patients I think are best served by surgical embolectomy or veno-arterial ECMO as a bridge to surgical embolectomy. I'm again concerned about sending a very, very unstable, clinically deteriorating patient to the IR suite. But there's unstable and there's really unstable. There's the kind of patient who's hypotensive, but can lay flat, looks relatively comfortable, and in those kinds of patients, you may be able to get away with catheter-directed lysis in those particular massive patients. Then there's the patients that fall right into the middle, and these are the really, really difficult ones. These are the submassive pulmonary embolism patients. And I look at all these things below when I decide whether or not I want to consider them high-risk submassive or a lower-risk submassive. I look at how they look clinically. Again, I look at, if they have an elevated pulmonary embolism severity index. I look at their echo. I look for things like elevated lactate, elevated BNP, troponin, large residual DVT. These are all worrisome features that I place you into this so-called high-risk submassive group. And out of those patients, the ones that have a low bleeding risk, we sometimes give systemic alteplase and sometimes we give catheter-directed lysis. But increasingly with time, because the safety profile is proving much more in favor of catheter-directed therapy, we are really using more and more catheter-directed therapy in this patient subgroup. In the higher bleeding risk, it's a no-brainer. It's definitely catheter-directed lysis. So high-risk submassive, high bleeding risk, this is the patient population where we're doing almost uniformly catheter-directed lysis. So in conclusion, I'm going to go back through the outline of this talk and attempt to summarize some of the major points from each individual section. We talked about pulmonary embolism definitions. We talked about how the majority of people like to split pulmonary emboli into massive, submassive, and non-massive based on the hemodynamic impact. Because a hemodynamic impact to the right ventricle is what portends your clinical course, it portends your outcome, and that's exactly what leads to worsening mortality in pulmonary emboli. With massive being those patients who are hemodynamically unstable, non-massive meaning completely stable and with normal echoes, and submassive pulmonary emboli being hemodynamically stable, but with echoes showing right ventricular dysfunction. And we can imagine that the mortality rates from each of those categories applies to the hemodynamic severity. We then moved on to talk about massive pulmonary emboli, and I emphasize that these are the kinds of patients in which you need to escalate care in any number of means. And escalating care means either the use of IV systemic thrombolytics, it means surgical embolectomy, it may mean catheter-directed therapy, and it may mean ECMO. And your decision amongst which of those particular types of care escalation is best suited for your patient has to do with patient characteristics, has to do with characteristics of their echo, has to do with their characteristics in terms of bleeding risk, with some of the higher bleeding risk patients being better candidates for things like surgical embolectomy, or catheter-directed therapy, and some of the lower bleeding risk patients being best suited by IV systemic thrombolytics. We then talked quite a bit about submassive pulmonary emboli, and in that we emphasized the importance of understanding right ventricular physiology and pathophysiology. By understanding that a right ventricle that is impaired can lead towards a spiral of worsening hemodynamic deterioration helps you understand which patients out of the submassive group should you escalate therapy in. I like to call them the high-risk submassive patients. And in doing so, you need to develop a means that suits you towards risk stratifying these patients. Whether it means looking at laboratory evidence of elevated lactates and troponins, whether it means getting a rapid access to an echocardiogram, whether it means using pulmonary embolism severity indices. There are multiple risk calculators that are out there, and I encourage you to find a tool that works for you in which you can decide who are my highest risk patients, whom should I intervene upon. We went through the systemic thrombolysis trials in the submassive population because there's a lot to be learned from these trials. Trials, in summary, all suggest that when you give thrombolytics, you can rapidly improve the hemodynamics. You can rapidly improve right ventricular performance. You can normalize the pulmonary circulation, but in doing so, it comes at a cost, and it comes at a cost of very serious bleeding. 20 to 30% risk of major bleeding, 3 to 5% risk of hemorrhagic stroke. But in deciding who are candidates, age turns out to play a very important factor, as we learned in a very recent meta-analysis. That under the age of 65, bleeding rate is remarkably decreased than in the group that's above the age of 65, and that's an important thing to take into consideration. And certainly there are other so-called absolute contraindications, such as recent surgery, intracranial pathology, such as a recent ischemic stroke or a history of a hemorrhagic stroke. These are all situations in which patients have a contraindication to getting IV systemic thrombolytics. And in those patients, we would advise moving forward with either anticoagulation alone or catheter-directed treatment. And in the submassive pulmonary emboli group, catheter-directed therapy is finding itself a very important niche. Both in the young patients, that even though they have a low rate of bleeding, I still think it is safer than giving IV systemic thrombolytics and may have some serious long-term advantages. And also in the patient population group in which you think that there's simply high risk in general towards further clinical deterioration, and maybe you also think that they're high risk for bleeding. In those particular patients, they also would benefit from catheter-directed therapy. I also talked about long-term benefits, and I suggested that clinical data isn't quite there yet, but there is a whole lot of signal towards the fact that there may be long-term benefits to escalating care upfront with pulmonary embolism patients. These benefits may include reduction of the development of pulmonary hypertension. It may include reduction of the development of chronic thromboembolic pulmonary hypertension. It also may be that you reduce and you improve upon exercise performance long-term. These are all potential long-term benefits of upfront therapy, upfront escalation of therapy. And again, if you can do it in a safe way, if you can deliver a lower dose over a longer period of time through a catheter, then by all means, I would suggest that this may be an appropriate place to use catheter-directed therapy. Now, I also went into quite a bit of detail about what catheter-directed therapy involves. And in many centers and many places, it does involve mechanical clot disruption, such as maceration, aspiration. In our center, we think that the best role for catheter-directed therapy is the installation of infusion catheters directly into the clot that allows us to instill thrombolytics at a lower total dose. We believe that clot maceration and aspiration's role should really be reserved for the massive pulmonary embolism population, the patient who's becoming so unstable that you need to do everything you can to get that clot burden down, to get blood from the right to the left. We believe that in the patients that have submassive pulmonary emboli, that it is best to simply put the catheter directly into the clot, to put them on an alteplase at 1 milligram per hour, to leave those catheters in place for 24 hours, and then to do a repeat pulmonary angiogram, and then make a decision about removing those catheters. Our experience is that the bleeding rate is quite similar to heparin, and the clinical trials that are out there so far also suggest a dramatically reduced bleeding rate when compared to IV systemic thrombolytics. It's important to remember that there does not currently exist a clinical trial that directly compares systemic thrombolytics to thrombolytics delivered via catheter-directed therapy. Hopefully that trial will come, but in the meantime, the evidence so far does suggest a lower bleeding rate, and I believe that to be true at this time. Lastly, I discussed developing a multidisciplinary approach. And the reason we feel that that is so important here at Cornell is that this is a common disease. It can be a very, very deadly disease. The ways in which you decide how to risk stratify a patient in front of you are actually pretty complicated. It involves a whole lot of clinical parameters. It involves interpretation of an echocardiogram. It involves interpretation of radiology. And the amount of tools that are out there to choose between now are only growing. Yes, you have systemic thrombolytics. You now have systemic thrombolytics at half doses that may be safer. You have all the different catheter-directed therapy modalities. You may have surgical embolectomy. You may need veno-arterial ECMO. We're talking a whole lot of choices in a very complicated disease. The best way we feel to do this is to get a group of people that are dedicated to this disease from multiple disciplines so they can all come into it with their own areas of expertise and contribute from those particular areas all together, where then you can come up with the best decision for your patient. You may have the cardiologist taking a look at the echocardiogram and saying that right ventricle looks terrible. You may have the interventional radiologist saying, yeah, but that clot is more distal and I'm not going to be able to get at it with my catheters. You may have the pulmonary critical care doctor saying, I think I should take that patient to the ICU, stabilize them further, and give low-dose systemic thrombolytics. Whatever those decisions may be, you put all your heads together, and I strongly encourage that you think of doing the same at your own institution. And with that, I think I'll conclude.